The next patient is a 50-year-old male who has lung, liver, and bone metastases. The LDH is slightly elevated, 1.4 times of the upper limit of normal. ECOG performance status is 1. The patient has a BRAF V600E mutation. So, Georgina, what is the frontline therapy for this patient in Australia?
So in Australia we have funding rules, which means for a BRAF mutant patient we have to give a BRAF and MEK inhibitor in the frontline setting, no matter what their disease status in terms of volume, LDH, etc. We actually don't agree with that. Things may be changing in some respects in the next few months, and I tend to try and find immunotherapy for my patients via clinical trials. If I had the situation, which I hope does change, where I could choose whatever I like in the frontline setting, the frontline immunotherapy I would choose for this patient would be a combination immunotherapy. They've got a slightly elevated LDH, they've got multiple metastases, the ECOG is 1. You would like to be more reassured about a response, and we do know that numerically the response rate is higher with ipilimumab combined with nivolumab, with all the other caveats we mentioned in case 1 in terms of overall survival.
So Mike, what's the data then saying that doing nivolumab and ipilimumab is better than a BRAF-MEK combination for this patient in terms of response and in terms of durability of that response?
Yeah, so, at this point, we're really in a data-free zone. At this point, we really don't have any trials that have said head-to-head for a patient with metastatic BRAF mutant melanoma, what is the right initial therapy? If you start with a BRAF-MEK inhibitor combination or you start with an immunotherapy combination, which of those strategies is most likely to result in long-term survival is really unknown at this point. And this is actually being tested in prospective clinical trials where patients like this are being randomized to start with combination targeted therapy with BRAF and MEK inhibitor versus combination immunotherapy with ipilimumab and nivolumab. And if and when the patients progress, they cross over to the other therapy. And this is really going to provide us with the definitive information about which of those therapeutic approaches is the right one to start with. And that being said, there is a third option. There are multiple clinical trials that are going on right now testing the safety and efficacy of combining targeted therapy and immunotherapy together, which is another intriguing hypothesis about how to treat a patient, particularly one like this, which, as Georgina mentioned, is a patient who has certain adverse or high-risk features that do make you concerned about their likelihood of progressing with our currently available therapies.
So Tony, what do we know about then, sort of outside of the clinical trial that Mike is talking about, what do we know about starting with a immunotherapy first, and then if the patient progresses, switching over to a targeted therapy versus the other way around, starting with the BRAF-MEK and then switching over to immunotherapy? Are the responses similar or are they different in these patients?
Well, all we have is biased reports. Okay. And I say the ecology for the people who have generate them. But if in a center patients with certain presenting characteristics are given immunotherapy or targeted therapy, and then you look back, how did those patients do? Well, the initial decision, which was non-randomized, will likely skew the results. But there is evidence that patients who have progressed on prior immunotherapy can still respond to a BRAF inhibitor-based therapy. There's evidence of the other way around. Patients who progressed on a BRAF or BRAF plus MEK inhibitors can respond to PD-1 blocking antibody. And actually the first trials, the registration of pembrolizumab and nivolumab in the US was first in patients who had previously progressed on ipilimumab, but also patients who had a BRAF mutant melanoma had to have received and progressed on a BRAF inhibitor. We know that when we do that, responses are lower. Which makes us think that either having more advanced disease is less likely to respond, or that maybe there's some overlap between the patients who respond to both kind of therapies. Those are things that obviously without a randomized trial we will not be able to tell. But I would argue that for an individual patient, we may not need a randomized trial. Because if I go back to this patient, a 50-year-old male with the LDH slightly high and a BRAF mutant melanoma, we can explain the data, both with BRAF plus MEK inhibitors, or with PD-1 alone, or ipi/nivo. And after explanation of the data, we get a conversation with the patient, and we start seeing how do things resonate, because there's pros and cons for all these therapies. Yes, we all want to have a response in the majority of patients. We want it to be durable, but we can have a durable response with maybe life-threatening toxicities, which we can have with a PD-1 and CTLA-4 combination, which would be unlikely to happen with a BRAF and MEK inhibitor combination. And then we have the patients who may say, well, I want to have the least toxic of all. I have my life as it is, and let's try to see if I can get a response, and you would go with a single agent anti-PD-1. So I think that even with randomized data, we can tell in a group of 100 patients what would happen to the majority, but it will never tell us what will happen to an individual patient. And I think we'll all continue to discuss personalized therapy.
So Robert, one of the things, just again to explain here, is again the significance of the elevated LDH.
Yes, so tell me about that, Mike.
So LDH, again, this is a serum assay for lactate dehydrogenase, and historically we've known that patients with stage 4 melanoma who have elevated LDH levels have a worse prognosis for overall survival from the diagnosis of stage 4 disease. What has been seen consistently across clinical trials with both targeted therapies and immunotherapies is that patients with high LDH have worse outcomes than patients with low LDH. In a patient like this, I think the scenario that we're looking at is we know that their chance of responding to immunotherapy is lower than a patient with a normal LDH. However, there's also very good data that if they do respond to immunotherapy, those responses can be quite durable. For patients with a high LDH, we actually know the targeted therapies do have very high response rates, probably higher than what we can achieve with immune therapy. But what we've seen over time is that the overwhelming majority of those responses are short in duration. And so I think the part that we end up debating, and this patient is a patient who has sort of very slightly elevated LDH, and they're not highly symptomatic. This is a patient where I think you have some time in order to get a response. I think the other place that we have this debate is patients who come in with markedly elevated LDH, high disease burden, and high symptomatology. That question of do you want to go with targeted therapy, which has a higher chance of actually providing symptomatic benefit, even if it's going to be short-lived, versus trying to use the immune therapy, where maybe your chance of getting the disease under control initially is shorter, but that there is potentially a chance for much more durable benefit if that's achieved. And those, again, are some of the concepts that we think about when we're seeing these patients with a BRAF mutation, particularly with the high LDH and other high-risk features.